Thank you. Morning, everybody. My name's Emma Weaver. I'm Deputy CEO of the ADHD Foundation, the Neurodiversity charity. And my job this morning is to talk you through ADHD, attachment and behaviour. Now, I've chosen to we're going to focus on it for about 45 minutes because what I want to make sure is at the end, we've got a good chunk of time for you to ask questions. We're going to explore attachment through the lens of relationships and how we can support our children and young people with ADHD and other neurodevelopmental conditions when it comes to relationships, sustaining relationships, and what might be some of the barriers or what some of the difficulties that our children might experience when we think about relationships, friendships, and attachments to other people. So let's start with what is ADHD. ADHD stands for Attention Deficit Hyperactivity Disorder. Now, ADHD sits under the umbrella of what we refer to as neurodivergence, and you might have heard the term neurodiversity. Neurodiversity is the concept that everybody thinks differently and that no two brains are exactly the same. And within the neurodiversity movement, we celebrate that. So we recognise that difference is a good thing. We recognise that for people with ADHD, there are characteristics of the condition that make things difficult at times, but there are also characteristics of the condition that can really support a child or a young person to thrive. It's about getting the right environment in place for them, the right support strategies and the right intervention in order to support them to do that. Now, for a long time, many neurodevelopmental conditions, ADHD is one of them. So we have ADHD, autistic spectrum condition, dyslexia, dyspraxia, dyscalculia. There's many neurodevelopmental conditions. But for a very long time, these conditions have sat under what we refer to as the medical model. Now, the medical model is also known as deficit-driven. And deficit-driven basically means that what we tend to do when we diagnose or we identify a neurodevelopmental condition, historically what we've done is we've labelled the challenges, we've labelled the difficulties. We've often labelled what our children can't do rather than what they can do. Now, this leads to quite negative viewpoints of those conditions and somewhat a level of stigma as well. And that's certainly what we've seen in the past when it comes to certain neurodevelopmental conditions. But what the neurodiversity movement is all about is about flipping that narrative, moving away from this deficit model, this negative, this labelling what children can't do. And it's about taking a strengths-based approach to these conditions. So it's about moving away from terms like disordered, delayed, impaired. My specialism, for any of you that have attended any of my training before, is early years. And something that I find really tricky is when we're working with children of age 3 and 4, and we use phrases like, this child at 4 years old is not meeting age-related expectations. Now, to be labelled like that, to use a phrase like that at that early stage of child development, often starts that child on a very negative journey. A negative journey going into education, but also a negative journey when it comes to accessing services and support. So what we do as a charity and what the neurodiversity movement is about moving away from that. So really challenging some of the phrases that we use, challenging how we label neurodivergent conditions, but also changing perceptions of these conditions as well, so that we move to strengths-based. What is it that our children can do? How can we recognise the differences in order to provide the support that's required? But also, how can we elevate the strengths in order to support our children to recognise that they are wonderful people, that they will achieve, that they can achieve. And actually, our job, either as educators or parents or health professionals, is to get the right support and the right environment in place for them. So ADHD fits very much in this movement. ADHD very much fits in the movement of moving away from this negative deficit-driven language. But one of our challenges with the title of ADHD is that we have two very deficit-driven words that sit within the title. So ADHD stands for Attention Deficit Hyperactivity Disorder. Now, when we break that up and we look at those as singular words, we have the word deficit in there. Now, deficit suggests that a person is lacking in something. It's absolutely not the case. When it comes to ADHD, actually what tends to happen for many children and young people is that they are over attentive. in the sense that their brains are working with so much information because the mind is busy. One of the characteristics of ADHD is what we call cognitive hyperactivity. And cognitive hyperactivity is when a child has a very busy brain. We often call it mind map thinking. Now, this can be a real strength. We hear many people in the world of business that talk about this mind map thinking. And this is the ability to think of multiple different things all at once, grasp onto them, be creative, think outside of the box. It's often referred to as the entrepreneurial nature of ADHD. So people with ADHD don't have a deficit in attention. They often have an overactive attention because they're attending to so many different things. Now, when we look at that through the lens of relationships, when we look at that through the lens of education, it can be tricky. If you've got a very busy mind, if you're experiencing hyperactive cognition, which is that busy brain, we might also see excessive speech, a child that likes to talk through their thoughts. I work with lots of children, and my role as Deputy CEO of the foundation is I work with many, many families, many children and young people, and many organisations as well. And often what I hear is children that they're supporting like to speak, like to talk through their thoughts. Now, if you've got multiple thoughts happening all at once and you're communicating those thoughts, that can cause us some challenges in our interactions because it can be sometimes difficult to keep on track with those conversations. And that's one of the characteristics of ADHD. But as I said, deficit would suggest that a child with ADHD is lacking, and they're absolutely not. We've then got that word at the very end, which is disordered. Now, for me, the word disordered, to label anyone as disordered is negative. And actually what we're doing is we're labeling them as different. We're labeling them as not the same as everybody else. And that can lead to a very negative sense of self. Now, when you have a negative sense of self, that can have a significant impact on motivation, self-esteem, and interaction. If I don't feel good about myself, if I feel negative about myself, how confident am I going to feel to interact and build attachments and relationships with other people? So this is why reframing the language is really important. Why taking strengths-based approaches to ADHD is important. Because actually, when you feel good about yourself, when you have high levels of self-esteem, when people around you are talking about the things that you're really good at, it builds confidence and it creates this space and this way of interacting with others where you feel like you're contributing positively to those connections. So unfortunately, we're stuck with the title of ADHD right now. I believe that over time, the title will change. I actually believe, and I'll talk you through this, that because we know ADHD very rarely sits alone, we know that children with neurodevelopmental conditions, they're often sitting with more than one. I actually believe that we won't have titles like ADHD and autism going forwards. I think in the next 10 years, and this is just my kind of thinking, is that what we will do is we will recognise a child's cognitive profile. We'll start to look at spiky profiles of diagnosis rather than individual standout labels. And I think that's where we will then see the shift towards this strengths-based. What can I do? What are my differences and how can we support it? So there's the title, Attention Deficit Hyperactivity Disorder. But sitting within that title, there are characteristics of the condition. Now, if we were to look at it through the lens of the medical model, we use the phrase symptoms. Now, to look at it through the lens of neurodiversity and a strengths-based approach, we prefer to use the phrase characteristics or traits. Because when we look at the term symptoms, symptoms often alludes to suffering from something. Now, people with ADHD can experience differences that make certain things difficult, but actually they can also experience characteristics that make things a strength and a positive for them. So under the neurodiversity strengths-based approach, we prefer to use the term characteristics or traits of the condition as opposed to symptoms. So the three characteristics of ADHD include hyperactivity. Now, hyperactivity is often what we think about when we think of ADHD. Usually I do an activity if I'm doing face-to-face training, and I will often say, give me words, tell me what words you would use to describe ADHD. And 9 times out of 10, the words that come back are words that label movement. So I hear words like fidget, on the go. I hear words like doesn't sit still, ants in their pants. I get all sorts of phrases, but those phrases or those words often label hyperactivity. Now, what hyperactivity is, kind of according to the diagnostic criteria, is a child that is on the go, lots of movement, struggles to sit still for long periods of time, physically very active. Now, the interesting thing about hyperactivity is hyperactivity can look different in our boys and our girls. Hyperactivity for boys often, and just to be super clear, everybody's different. So I've also worked with hyperactive boys that might not necessarily fit into this kind of description. But we tend to talk about the kind of general view of these characteristics. So typically, hyperactivity in a boy is a child that's very obviously physically on the move. Lots of big movements. We talk about gross motor, which is the big movements, and fine motor skill movements, which is the small movements. Fine motor skill movements might be nail biting, might be skin picking, might be a child that fidgets with things in their pockets. Gross motor skill movement might be a child that bounces, that climbs, that's on their feet, that is doing those big movements. Boys tend to demonstrate hyperactivity through those movements. What we see with our female presentation of ADHD is we might not necessarily see the big movements, but we'll see very subtle micro movements. I see a lot of girls hair twizzing, a lot of girls biting nails, a lot of girls, I see a lot of skin picking, or I particularly see girls kind of picking the skin around the outside of their nails and kind of biting around the outside of the nails as well. We also see cognitive hyperactivity in girls. So girls whose minds don't switch off. Lots of women and girls with ADHD are often misdiagnosed. They often don't get the label of ADHD until much later, because the characteristic of female hyperactivity is a busy brain, fast-paced thinking. Now, if you communicate that you can't switch your thoughts off, that your mind is racing, that you have 1,000,001 thoughts all at the same time, if you communicate that to somebody, that looks very similar to an anxiety-based condition. So what happens for our girls is they often get kind of taken down paths that are more the mental health route, that tend to be labelled with anxiety-based conditions and not necessarily labelled with ADHD. And that's because the presenting characteristic of hyperactivity might look different in our girls. We've then got the second characteristic, which is impulsivity. And impulsivity is known as behaving before thinking. So an action before a thought. There's an amazing speaker from America called Ned Hallowell. And Ned Hallowell labels impulsivity as a person with ADHD has a Ferrari brain, but with bicycle brakes. And I really like that as a concept, because I think that really helps us to understand that for some children with the impulsive characteristic of ADHD, they might race ahead with their behaviour. They might race ahead with making a comment to a group of people. And afterwards, they might go, possibly shouldn't have said that. Maybe I shouldn't have done that. When I worked therapeutically with children, my background is in education and my background is pastoral care. And I worked with many, many children with ADHD. And I'd often work with them after something impulsive had happened, where young people would say to me, this happened outside on the yard. I was in a social situation. This happened and now I regret it. I shouldn't have done it. But in the moment, I just felt it. Impulsivity typically isn't very logical. Impulsivity is driven by how we feel in the moment. It's impulsive. And impulsive by its very nature is I feel it and I do it. I don't necessarily put the thought into it before it happens. Now, when we think about that characteristic and we think about interactions and relationships, impulsivity can make it difficult. And it can make it difficult because impulsive behaviours sometimes can be unpredictable. So our children's behaviour in the yard at school or our children's communication might be difficult to manage if it's impulsive, if it comes from nowhere, if it's a little bit left field sometimes. Now, when we look at it through the strengths-based lens, actually, that person that is kind of communicating their thoughts, communicating their ideas, actually, that can elevate our relationships. To have somebody that's exciting to be around because they talk a lot, they're energetic to be around, and actually you don't know what's coming next, but actually that's quite exciting because it's positive. It can be harnessed as a real strength as well. But we do have to recognise that it can cause us difficulties too in our interactions and our communications. And then you've got the final characteristic, and the final characteristic is inattention. Now, when we look back at the history of the language that's been used around neurodevelopmental conditions, the negative kind of deficit-driven term that described inattention was sluggish cognitive tempo. Luckily, we don't use that phrase anymore. And I'm really glad, because it's not a positive one. To describe anybody as sluggish isn't particularly strengths-based or particularly positive. But what it basically means is, for people with ADHD, they just take a little bit longer to process information. If you picture ADHD as a difficulty with processing, that can be a really helpful word to think about when you're thinking about supporting children and young people. And when you think about interactions with your child, a child with weak attentional control can find it difficult to sustain attention. Now, if you imagine, we've all got an inner ear and an inner eye. An inner ear is the way that we store information based on the things that we hear. So that's verbal communication. So, and I've had countless parents that say to me, I ask my child to do something and they just don't do it. Or I ask my child to do something and they'll do part of it, but they won't do the full. Or I ask my child to do something and they appear to be ignoring me. Now, when we look through the lens of inattention, they're not necessarily ignoring you. They might be, because children like to push buttons and it's natural that these things happen in communications. But when we look through the lens of ADHD and inattention, actually it might be that there is just a slower processing of that information. They get there, it just takes a little bit longer. Processing speed is a little bit slower, so we just have to take our time when it comes to verbal communication. Now, when we think about the inner ear, that's remembering things by things that we hear, but we've also got an inner eye. And an inner eye is remembering things through the things that we see. So that's visual structures, supports in our environment that we can look at, that we can hold, that we can see. We call it an externalizer. For children with ADHD, they have stronger eyes than they do ears. If I can see it, I'll remember it. If I can touch it and interact with it, I'll remember it even more, because sensory motor kind of engagement really helps me to remember that information. So when we think about that in interactions, for many of our children with ADHD, if we're struggling to retain the spoken language, it can lead to some levels of difficulty with interaction and communication. If it takes me a little bit longer to explain, we talk about expressive and receptive language. If I'm struggling to express myself because I just am trying to piece together my thoughts in order to then articulate what I'm thinking, that can lead to delays in interaction. And that delay in interaction can lead to difficulties with attachment and forming relationships. So we just have to be mindful of that, because when we think about that, that's then how we can think about supports and strategies as well. Now, there are three characteristics of ADHD, but you don't have to have all of them to be diagnosed. What we're learning now and what we're seeing, and it's starting to come through within our medical model of diagnosis. So when your child goes to a paediatrician and they receive a diagnosis, we are starting to see subtypes. Now, there are three subtypes of ADHD. There is the predominantly hyperactive impulsive. So that's a child with hyperactive characteristics and impulsive characteristics, but very low level inattentive. Now, you'll know this. This is the child that doesn't stop moving, is impulsive in their behaviours, but is always listening. Now, when I worked in education, these were our children in our classrooms that were on their feet, that were walking around, that might have been wanting to climb or touch things or be on their feet. But these were always the children that if you ask them a question, they'd always respond. They're listening. They might not look like they are, but they are. They need that movement in order to be able to attend and understand and learn, essentially, and concentrate. We've then got the second subtype, and the second subtype of ADHD is predominantly inattentive. Now, if you're predominantly inattentive, what that means is you might not necessarily demonstrate hyperactive characteristics or impulsive characteristics. But what we do see is that you are struggling to retain information. You might be struggling with planning, organising, problem solving. It might be that that characteristic presents as being forgetful, struggling to remember key bits of information, finding it difficult to demonstrate, I suppose, independent tasks, because independent tasks take something called executive functioning skills. When you have ADHD, there is often a weakness in the executive functions. And the executive functions are the skills that help us to plan, reason, problem solve, regulate our emotions. Now, when you have a weakness or what we call executive function dysfunction, what happens is you struggle to retain. to sustain motivation, to plan and problem solve. And that can often be a characteristic that we see with the predominantly inattentive ADHD. Now, what we also know is that for many children with inattentive ADHD is that they tend to go under the radar a lot longer. So it's not as easy to spot. So the inattentive traits of ADHD, because they aren't as obvious, hyperactivity, impulsivity, you can see it. A child that moves a lot in our classrooms is on the go all the time. It's very clear. We can see it. Children who are predominantly inattentive sometimes aren't seen as easily because those characteristics aren't as obvious. It can be common for the female presentation to be more predominantly inattentive. But I actually believe we see hyperactivity with girls. We just don't necessarily see hyperactivity in the same way. So hair twizzing, nail biting is hyperactivity. But in a boy, it might be a boy that's on his feet, that's up and down a lot. It's just how we view hyperactivity. And then you've got the final subtype, which is the combined. Now, if you have the combined subtype, that means that you have all of the characteristics all together. And we are starting to see paediatricians labelling and psychiatrists in the adult world of ADHD starting to recognise and label those subtypes, which is really helpful. Because if you know what subtype you are, then we also know how we need to offer support and guidance. Because a child that's predominantly hyperactive impulsive will need lots of support around movement, around emotional self-regulation. A child who's predominantly inattentive is going to need lots of support with the executive functions, with the planning, the problem solving, the reasoning, externalizing information. So it is a guide and it can be really helpful. Now, as I said, ADHD very rarely travels on its own. There's something called co-occurrence. And co-occurrence means that if you have one neurodivergent condition, you're very likely to have another one. This is why I think the phrases such as ADHD and autism as standalone conditions will change over time. Because what we know from research, but also anecdotally, what I see every day in my work is that most children and young people are not just sitting with the one characteristic of one neurodevelopmental condition. They're often sitting with multiples. I call it a sprinkling of lots of different things. Now, this was the best way that it was explained to me. This was explained by Professor Amanda Kirby, who is the CEO of Do It Solutions. She's also the chair of the ADHD Foundation. We're very proud of that. She's also a wonderful lady to follow on LinkedIn and Twitter because she's constantly providing information about neurodivergence. But she explains it in this way. She says, imagine every person that you meet, they're carrying a bucket around. And in their bucket, lots of different coloured bouncy balls have been thrown in. So for one child, they might have had 5 coloured bouncy balls. For another child, they might have 5,000. Another child might have 5 million coloured bouncy balls. Everybody's bucket will look different because we're all different and everybody's profile is different. Now, if you imagine each coloured bouncy ball represents one of the neurodevelopmental conditions. So if you look at bucket A, person A, they've got different coloured bouncy balls thrown into their bucket. But the coloured bouncy balls that stand out particularly are labelled dyspraxia, ADHD, dyslexia, and developmental language disorder. Now, we also know that, and you can see it in the picture, that around 3/4 of the way up the bucket, there's a line. Now, that line represents the diagnostic threshold. So what we can see in person A is that this is a child who has demonstrated significant levels of dyslexic characteristics, enough that they've been assessed, they've been looked at, we've gone through the diagnostic criteria, and this child meets a clinical threshold for a diagnosis. So what that means is this child has received the label of dyslexia. But you can see in their bucket, there are other sprinklings of other neurodevelopmental conditions, but those other neurodevelopmental conditions aren't significant enough to receive a label. So they're not impairing the child enough that we need to give them that label and that diagnostic term from a clinical perspective. Doesn't mean to say those differences don't exist, they're just not significant enough to be diagnosed. But person A in this situation is, I suppose, a lucky one because they have been recognised as being neurodivergent. So we can make reasonable adjustments, we can provide support because we know that they're dyslexic. It's person B. And this is a child that I see in every classroom, in every school I go into. It's an adult in every business, in every workplace. I see this all the time. And this is a child or young person that has had many more coloured bouncy balls thrown into their bucket. But there isn't one standalone condition that is significant enough that it meets a clinical threshold for diagnosis. So this is a child that's sitting on a referral pathway. This is a child that school have referred them because they're seeing traits of different things. They've gone on the referral pathway. They've met a paediatrician, and a paediatrician has said, no, this child isn't ADHD or isn't dyslexic or isn't autistic. But there are still an element of neurodivergence there. It just doesn't meet a formal clinical level for diagnosis. And these children are what we refer to as sub-threshold. And if you're sub-threshold, that basically means that you don't have a label or a diagnosis, but your presentation still demonstrates that there are differences there and there might be challenges that you're experiencing. So it's important that we hold this in mind when we're thinking about our children and how they form relationships and how they interact with others, because they might have a label of ADHD, but there might also be co-occurring conditions that are also playing a role in why it's difficult for them to form attachments. So a child with ADHD and co-occurring autism might experience more of a difficulty with forming relationships, because autism, a characteristic of autism, is difficulty with social interaction and communication. So I wanted to make sure I covered that in this morning's webinar, because I feel it's important that when we move on to exploring attachments, that we actually think about what are the presenting characteristics for our children. You know, they might have a diagnosis of ADHD, but actually, are we querying whether there is other neurodivergent conditions there? And actually, statistics tell us that there probably is, because there is a high likelihood that children with ADHD have something else sitting alongside it. We know that 40% of children with ADHD are likely to be dyslexic. So it's very, very common that ADHD and dyslexia sit alongside each other. But I see lots of children with ADHD and autism, ADHD and dyspraxia. Co-occurrence is the rule, not the exception. So what is attachment? Now, attachment theory helps us to understand how in our early years we form attachments to our main caregivers. And attachments are the ability to form bonds. Sorry, I've clicked a button too soon there. Apologies, guys. Is the ability to form relationships and bonds with other people. Now, for some children, and today's focus is on our children who are neurodivergent and how they form relationships with others. For some children who have experienced difficulties with early attachments because of early life experiences, what happens for those children is sometimes it can be difficult based on early exposure to weak attachments, means that they struggle to form attachments as they get older. For children with neurodivergence, attachment difficulties might be related to the nature of their condition and the characteristics that they're presenting with. Sorry, guys, it keeps jumping ahead of me today. Bear with me 1 minute. So if we think attachments are the ability to form relationships and bonds with other people. Now, we have multiple attachments. So multiple attachments might include a parent-carer to child attachment. So how we as adults, parents and carers, attend the relationship that we have with our child. There is also the teacher-to-child relationship and bond, a child-to-child attachment, so friendships, peer groups, that's a bond that can be created, sibling-to-sibling bonds and relationships, and also external family members to the child relationships. Now, our children will be forming relationships and bonds throughout their growth and throughout child development. The first bond, the crucial bond, is that parent-carer to child bond that happens. Because the parent-carer to child bond in the very, very, very early stages of child development typically dictates a child's ability to form future bonds. So a securely attached child, a child who has had a strong start, has created a strong relationship early on, has the ability to then go into the world and create those secure attachments with those additional bonds and relationships that we make. Now, for children who have had weak starts or have had difficulties forming attachment in those early stages of child development, that can lead to difficulties as they grow up. Now, this is where it's very difficult to look at attachment and look at neurodivergence as two separate things. Because for some children, They can have that positive start. They can have that established, secure attachment with the main caregiver in their early years. But by the very nature of neurodivergence, potentially difficulties with social communication and impulsivity, that then leads to difficulties with forming attachments, bonds, and relationships. So what happens is when our children with neurodivergence struggle to form those bonds or form those relationships, we might see a behaviour. Now, when we talk about behaviour and behaviour analysis, we always use the iceberg theory. And the iceberg theory is the idea that actually what we tend to see is what's happening at the tip of the iceberg. So there are behaviours. So the behaviours that we might see coming from our children or young people is a child that is refusing to engage in social relationships, a child that prefers to play alone. They might prefer to have solitary play, a child that prefers to not to be alone and not necessarily interact with other people. They might be withdrawn from social situations. They might have a high level of anxiety in social experiences, or even whether it's small group, large group, or on a one-to-one. We might see a behaviour that looks like refusal or reluctance. We might see emotional reactivity. I work with lots of children who are neurodivergent, who become emotionally overwhelmed in social situations. So we might see that their behaviour increases, their emotions become greater, and their ability to control their emotions become impacted by those feelings. Or some of the behaviours that you might see at the tip of the iceberg might be negative self-talk. So I work with children who are neurodivergent who say that they haven't got any friends because people don't like them, that they haven't got any friends because they're not good at something. Now, research tells us that a common characteristic associated with ADHD is something called rejection sensitivity dysphoria, RSD. And RSD is very common for children and young people with ADHD. And RSD is basically the concept that people who experience RSD have a very negative sense of self. They're very self-critical. They are also very emotionally reactive to negative or critical feedback. They're often frequently looking for rejection, for negativity, for critical feedback. These are our children in our classrooms or in our home environments that go, that teacher doesn't like me. I'm not going to that class because the kids in that class don't like me. They hate me. They think that I'm not nice to be around. RSD is a real thing that is associated with ADHD, which can have a significant impact on our attachments, on forming relationships and bonds. Because if you see yourself as negative, if you are actively looking for people to reject you, that can lead to a lack of motivation to engage and to develop those strong emotions. Now, RSD is often, I believe, a result of critical negative feedback. It's believed that children with ADHD experience between 50 and 80% more negative words that label them than any other group of children. So when we hear phrases like naughty, when we hear phrases like dysregulated, a child, even the phrase inattentive, negative language is often used to describe a child with ADHD, which then leads to this incredibly negative sense of self. So what we have to do is we have to work to mitigate that. Lots of praise, lots of strengths-based language. This is what you struggle with, but this is what you're wonderful at. You're brilliant at sport. Let's get you to the football on a Saturday and play football. If you're struggling with the academics, what can we help you to thrive with? How can we support you at home to feel good about yourself? How can we praise you and elevate you to increase that kind of self-esteem? So the tip of the iceberg is the what we see, the behaviours that we might be looking at. It's underneath the surface is how we need to analyse it. So are we seeing those behaviours because the child is experiencing social communication differences? Do they have co-occurring autism, which means that they are struggling with expressive language and receptive language? Are they struggling in social relationships to communicate their thoughts, but also to understand what other people are communicating to them? It's a common characteristic of autism. And when we look at ADHD and co-occurrence, it might be that our children are struggling with that backwards and forwards of communication and interaction. It might be that they're struggling with sharing and turn taking as to whether and that's leading to differences and difficulties with forming bonds and communication. We also know that there are environmental inhibitors. So many children with neurodivergence have differences with how they interpret the environment around them. We hear the term sensory integration differences. You might hear sensory processing. You might hear the term peripheral distractors. Basically, what that means is our environments are overwhelming. So for a child with ADHD, when it comes to them joining a social situation, if the environment is busy, if it's loud, if it's smelly, if there's loads of kids around and it's too busy for me, that can be an inhibitor. That can stop me from interacting. I can become really overwhelmed because my environment doesn't feel right. So my ability to communicate, to build a bond, to build a relationship is impacted by the fact that this environment is just too much for me. We also know that a common characteristic of ADHD is self-regulation. And self-regulation is behavioural regulation. So actually, maybe a child's hyperactivity, because they're busy, because they're impulsive, because their behaviour might be unpredictable. For some children in social situations, that can lead to difficulties with interactions. It might be that some children in the peer group might find hyperactivity difficult to navigate. This is where self-awareness and understanding for children is really important. And I'm going to come in onto strategies. So it's the theory bit now, but the latter bit is about strategies. And one of the biggest strategies is self-awareness. We call it psychoeducation. Our children need to understand ADHD in order to understand themselves, and how they form relationships. Another reason why we might see the behaviours or the differences with interaction is because of cognitive or executive function differences. So inattention, a child whose processing takes a little bit longer, actually in communication, children are busy, life is busy. If a child is taking a bit longer to respond, our children in our peer groups don't always have the patience to wait. So that can lead to different difficulties. If there's difficulties with planning and organising and problem solving, when we think about the play environment, if a child with weak executive functions is struggling to plan their play, problem solve when play goes a little bit wrong, emotionally control themselves when play doesn't quite go their way, then if they're having difficulties with that, that can interact bonds, relationships and interactions. Rejection sensitivity dysphoria and past experiences. Lots of our children who are neurodivergent might have had negative past experiences. They might have experienced separation, they might have experienced grief or loss, or they might have just experienced a peer group that has not been necessarily as welcoming. We see lots of children who are neurodivergent struggling with interactions in peer groups and relationships. So those past experiences might impact how a child or young person then sees themselves and confidence to engage and to build relationships. So with all of that in mind, and that's a lot to kind of think about, but with all of that in mind, what do we do about it? How can we support our children? So there's lots of things that we can do, lots. And this is the wonderful thing about the strengths-based approach to neurodivergence, is that it's just about understanding, and once we understand, tailoring our support. So first point that we need to do, in order to support behaviour, we must teach our children skills in emotional self-regulation. Now, we have an approach at the foundation. It's called the 3-step approach to self-regulation. Now, I facilitated a webinar about 2 or 3 weeks ago. It's on the Witherslack website. So you've registered, you will be able to access this. So I won't go into too much detail, but that session focused very much on strategies for self-regulation. But our 3-step approach is we've got to support children to understand emotions. We label emotions when we see our children feeling them. So we have a phrase, I think you are feeling. I think you're feeling happy. I think you're feeling sad. I think you're feeling worried. I think you're feeling angry. We label emotions as much as we can. Label our own emotions. Label the emotions of our family members. When Nan comes through the door, label how you think she's feeling. Indulge them in the emotional words. We then need to support our children to recognise their emotions. So how do my emotions make me feel in my body? So we up-level our coaching statements. We say to a child, I think you are feeling because. I think you're feeling happy because you've got a big smile on your face. I think you're feeling worried because you're biting your bottom lip. For our older children, we might broaden the language. So you might say, I think that you're feeling anxious because you're picking at your eyebrows or you're biting your nails. So what we're now doing in this 3-step approach is we're labeling the emotion and the physical reaction. And then once we've done that, And that might take a little bit of time. We've got to embed the understanding first, then we've got to embed the recognizing, then we move on to embedding the regulation. So what we now do is we offer a tool to help them. So I think you're feeling worried because you're biting your bottom lip. Shall we go and do this to manage that feeling? Now, if your children, when they get angry or worried, become quite physical, then we offer them a regulation tool that manages that physical feeling. So it might be, I think that you're feeling angry because you're clenching your fists. Let's go and get a resistance band. Let's go and use some therapy. Let's go outside and climb a tree. Let's get that physical feeling out of our bodies. If your child is talked excessively or their mind appears to be running away with them, or I work with lots of children whose breathing runs away with them when they get a little bit overwhelmed, breathing techniques can be really helpful. We talk about the hand breathing, finger at the base of the thumb, big deep breath in, hold at the top of the thumb, and big deep breath out. We follow the outline. There's tons of apps out there. Headspace for Kids is a brilliant one. And there's mindfulness videos on YouTube, loads of things that we can watch to support emotional self-regulation. So we label the emotion, we label the physical feeling, and then we label the regulator. And what we're doing is we're providing a three-step approach to developing skills in emotional self-regulation. But as I said, I go into much more detail about this on the previous webinar. So please feel free to have a little look at that one after today's session. Also, create spaces at home to regulate. I often call them kind of a space where I can just take time out from it all. Quiet spaces, a space where I can step into it and I'm not bothered by anybody. Might be that actually after a really busy day at school where social interaction has been a huge component of my whole day, actually for the first 20 minutes when I get in from school, I don't want to talk to anybody. Work with teenagers that go, when I get home, I just want to be on my own. Now, that can be a concern if they want to be on their own for too long, and we might be worried about that as parents, but actually we can fit time alone in as part of the schedule. So just time out from it all is okay. 20 minutes when you get in from school, go and sit in your space that's quiet, that's out the way, just to give you a bit of downtime. We need that as adults. When I get in from work, the first thing I do is sit on the couch with a cup of tea. And that's the moment where I just desensitize from my day. And then I can crack on with the rest of my evening, but I need that downtime before I can then motivate myself to keep going. Create emotionally safe spaces. Talk about emotions, label emotions, talk about your own, look at books. There's some amazing books about emotions out there. Watch films and talk about the emotions of the characters. It's important that our children hear us as adults talk confidently about our emotions. And also understand that not one emotion is negative. Anger is okay. Everyone gets angry. Me at 37, I still get angry. Behavior is where it's right or wrong. So if I get angry and hurt somebody, then that behavior is not okay. But the angry feeling is not the problem. Anger is okay. It's okay to feel like that. Sometimes we see angry as a bad thing, but actually it's not. And I think if we support our children to recognize that it's not a bad thing, then they're more likely to express those and communicate their feelings. We need to normalize it. Normalize the fact that we get angry. Normalize anxiety. Normalize sadness. We all feel these things and it's okay. It's what do we do about it to manage it that's important. Teach anxiety. Often anxiety is the root cause of so many difficulties for our children. Now, I love this. This is the anxiety cycle. And I think this really helps us to think about children who are refusing or avoiding things. This can be helpful when we've got children avoiding school or avoiding social situations. Now, this is the idea that we enter into this cycle when we're scared or worried about something. So at the top of the cycle, we've got the perceived danger. Now, for a child, the perceived danger or the thing that I'm frightened of might be social situations, might be going to a party on a Friday night. It might be going into the maths lesson with a group of people I don't know. It might be for our younger children going to a party with friends from my class on a Sunday. I'm not used to it because I just see them Monday to Friday. The perceived danger is something we fear. Now we then enter into this cycle of avoidance. We avoid it. We refuse to go. We say we don't want to go. We get anxious about it or worried. Now, in that moment, we then have a brief sense of relief if we get the opportunity to avoid it. So the more I don't do it, the easier it feels. You're not putting me in a position that elevates my anxiety. I've avoided it. So in that moment, I feel okay. But what happens is if we avoid too long, the thing that we've perceived as dangerous actually gets bigger. it becomes even scarier. So that social communication and interaction opportunity actually becomes even bigger, because by avoiding it, I've made it feel much more elevated, much more anxiety provoking. So what we talk about is we need to teach children to understand anxiety. We need to teach children to recognize that anxiety does peak for everyone. When you're feeling anxious, your anxiety levels increase, they peak and they hit a level, but they will never stay at that level. When we sit with anxiety, anxiety slowly, as we sit with it, starts to decrease. But we have to put ourselves in a position to test that out. And avoidance doesn't allow us to do that. So this is where, with our teenagers who are avoiding school or avoiding social situations, we need to talk to them about avoidance leads to the thing that we're scared of feeling much bigger. Sometimes tackling it can be a really good starting point. This is particularly helpful for our teenagers who might be transitioning out of education into uni, into the world of work, where actually for such a long time, if they've been allowed to avoid these situations, the transition into the world of work becomes much greater, because we've sometimes, and gosh, I've certainly done it, we want to protect our children. We might want to wrap them in cotton wool and take them away from those things that feel stressful. But actually what we're doing is we're not giving them the opportunity to learn how to cope. And resilience is a really big factor when it comes to neurodivergence. We need to teach skills in resilience, and that these situations might be tricky, but these are the things that we can do when we feel overwhelmed in those situations. Something that's also really important for lots of our children who are struggling with potentially separation, anxiety around interactions, predictability. Externalize things, communicate regularly. So children who are neurodivergent often crave a need for certainty. They want to know. I work with so many children that ask questions. What's happening tomorrow? What we're doing this morning? What's my week going to look like? Where am I at the weekend? And that's because of weak executive functions. They crave certainty. So predictable routines. Externalizing routines onto visual structures, using timetables, using calendars. This is what your day looks like. When I understand what my day looks like, I feel less anxious. When I understand what my week looks like, I feel less anxious and more likely to be able to go into school and communicate more effectively, because I'm not running on this anxiety. Now, one of the challenges with the need for certainty is that life isn't always certain. And this can be really difficult, particularly if we've got children with co-occurring ADHD and autism, because often that need for certainty means they need definites. But life isn't always definite. So I have a strategy that I use, which is the let's question mark it. So if we know the plan is on Friday, you're going to go to your nan's for tea. But actually, sometimes nan can cancel at the last minute, or nan might get the opportunity to go out. So there's a chance it might not happen. So it might not be certain. I'm going to put a question mark over that. So we get a picture of a question mark. So this is what your week looks like, but Friday's got a question mark over it at the moment. It might be that you do it from a week's perspective. It might be that you do it in the day. It's Saturday. You'd planned in the afternoon to go to the park, but with the great British weather, it's June and it's rained and it's cold. That might change because you've looked at the weather app. Let's just question mark that. I'd like to go to the park this afternoon, but I'm going to put a question mark over that because it might rain. Expressing it and communicating it regularly helps to manage that need for certainty. And a huge one is, if you know that there's going to be a separation, if you know that you're not going to see your child for a little while, or there's going to be a break between seeing each other, just prepare them. If they're going to be with a different adult, if they're spending the weekend with a different person because you're going away, prepare them for that. Who are they going to be with? When's it going to happen? And when are you going to return? And a big one, particularly when it comes to the need for certainty and separation and attachment, don't make promises that you might not be able to keep. Children who are neurodivergent will remember what you've said. So if you've promised that you're going to pick them up from school, but in the back of your mind, you're thinking, I might not be able to because I've got a feeling I might have to work late. Don't make that promise. Question mark it. Because what happens for many children who are neurodivergent is that they will want you to stick to your word, and they'll remember your word. So if we don't know, and if we make a promise that we can't stick to, our children start to become untrusting of us. So that question mark strategy can be really helpful in those situations. Now, other things that can be really helpful. I've got lots of families that say the transition to school is really hard. I can't get them over the threshold. They're refusing to go. They won't separate from me. Now, a lovely idea, and this has come from Beacon House, Beacon House is another charity, a wonderful charity, and they specialise in attachment. So there's tons of resources on there with lots of information about strategies to support children who are struggling with attachment. But some of their suggestions are transitional objects. So if you've got a child that's anxious to go into school, what can we take that acts as the bridge from home to school to support them to manage that? Is there an object that they can take from home that sits in their blazer pocket that reminds them of home? It might be, and a lovely idea was the parent had a heart. It was a cut-out red heart, and the child had a cut-out red heart. They wrote on it, and they swapped hearts. Child put the mum's heart in the jacket pocket, and the mum put the child's heart in her back pocket of her jeans. That happened every morning. Take that into school with you. That visual representation reminds me of my parents or carer at home. Younger children, we talk about transition boxes. So a box that sits in my classroom that's got things from home in there, or a box that sits in my house that's got things from school in there. I love the idea of postcards. So one school that I work with, they post a postcard over the 6 weeks holidays to those children just to say, I'm thinking about you. Now we can do that with our children. It might be that we've got parents who are separated. It might be that we've got children who are under social care, so there might be respite that's happening. It might be that for a period of time we don't see our children. Actually, some of these postcards, I'm still thinking about you. That connection is still there. And then finally, building resilience. Building resilience is key. What we have to do is we have to support our children to understand that sometimes there are certain situations that elevate our anxiety. Now, when our anxiety levels are elevated, we might hit that avoidance cycle, or we could tackle it. And this really, I think, is a lovely way of trying to explain it to young people. It's the idea that we've all got zones. We've got our comfort zone, our stretch zone, and our stress zone. Our comfort zone is where we sit when we're comfortable. But in this analogy, it's not a great place to be because we don't learn and we don't develop. We've got our stretch zone, and our stretch zone is where there might be elevated levels of anxiety, but they're good. It's good motivating anxiety because we learn and we develop. And then we've got the stress zone. And that's when we are overwhelmed, we can't cope because we've been pushed that far that we're not able to learn or grow because we're too overwhelmed. Now we can plot it on a 5-point scale. So we can say to our children and young people, when we think about social interactions, where are you most comfortable? Might be for one child, I'm happy when I'm with me now. When are you stretching yourself? But remember, stretch is good because that's how we grow and how we develop. So it might be I stretch myself when I'm in the playground. What's your panic? Panic is when you invite me and ask me to go to a party on a Saturday with a group of people that I've never met before. And then we negotiate with children. So it's not about saying, I know that makes you panic, so we're going to not do it. But actually we negotiate. We're going to the party on Saturday because it's a wedding that we've all got to go to. I know this is going to feel overwhelming for you. So what comfort can we do to build the comfort in along the way? And it might be, I'll go to the wedding, but can I have time out times? Is there a room I can go to? Is there a space outside where I've got my iPad and I can have some breathing space? Now that negotiation, that conversation helps a child to regulate, helps a child to know that we're taking into consideration that this situation might be overwhelming, but I'm thinking about how I can support you with that as well. Guys, I hope that was helpful. As I said to you, and I referenced it in the session, that there is another webinar that's happened. It happened a couple of weeks ago that will lend itself to more strategies for you. So please feel free to have a little look at that website, that webinar, sorry. So in the meantime, I think we'll just open it up to questions. I can see in the Q&A box that some questions have already come in. I'm happy to answer those as we go along.
Yeah, brilliant. Thank you, Emma. That was a brilliant presentation. Like you said, we've had loads of questions coming in, so we'll try and get through as many as we can in the 5 minutes that we've got. The first one is, my little boy is only 4, so we know he can't get any diagnosis yet, shows a lot of behavioural issues. He's adopted, and we know birth family had ADHD, mental health and autism, all within siblings and birth parents. My child's school says he's full of energy and hard to calm down. He also gets quite angry. Gets angry quite easily and doesn't handle transitions well. What support can I get him?
That's a great question. And obviously, one of the things that you're reflecting on is he's a child where there is historic background information about birth family. So we know that these conditions do run in families. So ADHD is genetic. So we do know that if parents have ADHD, then it can be common that a child has ADHD as well. But there's also the kind of added layer of that is I'm just reading it. You've adopted, I think, or fostered possibly. I'm not sure, but so there's also then obviously the layer of attachment there too because of early experiences. A big thing that can be really helpful, and we've looked at some of those strategies, is starting with early to support them to learn about self-regulation and how to regulate. Visit the Beacon House website. There's lots and lots of strategies on there. If you're struggling with transitions, then lots of communications, lots of externalizers. Children that struggle with transition often are seeking a sense of certainty. They're seeking a sense of routine and to understand what's happening. So having a visual timetable can be really helpful. This is what your day looks like. This is what we're going to be doing now. This is what we're going to be doing next. This is what we're going to be doing later on. All of those visual externalizers make it concrete. So a big thing that might be helpful for him, especially at 4, is that rather than communicating what's happening verbally, you back it up with some pictures and some images. So that's where your visual timetables can be really helpful. Teach him some of those strategies and emotional self-regulation as well. What we also know at 4, and as I said, my specialism is early years, is there's often a need for rough and tough play. So school are saying that he's full of energy. Often that energy is directed through a need for resistance, a need for pulling and stretching. So give him loads of opportunities to climb, to crawl, to use his body, because that will be regulating. It's called proprioceptive input. Children with ADHD who are busy, whose bodies are moving a lot, need a lot of opportunities for resistance activities. So I'd recommend that. I'd also recommend watching that webinar from a couple of weeks ago because we talk about that in that webinar too. I hope that answers the question.
Brilliant, thank you. I will, in the follow-up emails, I'll send that webinar as a link so everyone can watch that as well. The next question is, my son is diagnosed with ADHD and has high autistic traits. His school says he has low self-worth and low self-esteem and lack of resilience. They said it's stubborn and he often won't try anything. Can you suggest anything to help?
Really tricky to use the word stubborn because it's stubborn, again, it's not particularly strengths-based either. There's a reason. And when we looked at the iceberg theory before, that stubbornness that they're labeling actually is a child that is struggling right now. And it might be rejection sensitivity. It might be that he has elements of negative self-talk. Now, it can be difficult to manage negative self-talk, but what we need him to experience is highs and opportunities to thrive. I find children with ADHD in particular, they love a job and a responsibility. So, what responsibility can we give him that he can achieve at home? And we can only control what happens at home, but we can talk to school about what opportunities does he have in the school day to demonstrate a win or a success. And I think jobs could be really helpful. So I've worked with families where the child with ADHD has got a job at home, and if the child doesn't do that job, then actually it's a really important one for the functioning of our family. So give him lots of roles and responsibilities where he's going to get a few wins. And sometimes direct praise can be really hard. So I find with some children that if you say to them, I think you're wonderful, or you've done an amazing job there, they can find that difficult to kind of respond to. It might be a bit overwhelming. But actually saying to them, do you know what, can you do this for me? Because that will really help me. It's an indirect praise. I'm giving you a role because I know you can do it. So, and that's strengths-based. So I would recommend lots of opportunities for that so that he starts to develop a more positive sense of self. Also, understanding ADHD, understanding himself. We've got some brilliant booklets on our website, and it's supporting children to understand ADHD. So psychoeducation, it's called. Help your child to understand their condition, because when they understand themselves, they can then understand maybe where the kind of differences are or what they're experiencing too.
That's brilliant. Thank you, Emma. I think that's actually all we've got time for today. I know we have loads of questions coming in, but we'll try and make a note of them and hopefully try and get them answered in the future. And I'll send out the old recording so everyone can catch up on that as well. So yeah, just want to say a big thank you to Emma for a brilliant presentation. Our next webinar is with Anne-Marie Harrison from Ideas Are Fresh Exploring PDA. To register, head to witherslack.co.uk/webinars. So thanks again for joining us. Thank you, Emma, and bye for now.
Thanks, guys. Take care.